So first of all, this is going to be a 75-minute lecture on pediatrics. And we can't obviously cover the breadth of pediatrics in 75 minutes. And that's why through this program, you've received information in other lectures. You know, we're talking about Salter-Harris fractures. We're not going to be talking about that today in this lecture. We've covered it through the orthopedic stuff. But there'll be some spaced repetition because I'll go deeper into HUS during the pediatric lecture. But this is just some core stuff that wasn't covered in the other lectures to put into one box that we're going to call pediatrics. Now, I work at a community hospital. I don't work at a tertiary or quaternary center. I work at a community hospital, and I see everything. I see womb to tomb. I see cradle to grave. So I see children. I'm the ologist in the building, right? I'm the pediatrologist, the orthopathologist, the gynecologist. Everything comes through the emergency department. Who here sees kids? The rest of you are scared, right? Okay, this will hopefully go, oh. That peaceful picture of the middle is how you should feel when seeing children. Don't panic, just deal with the problem. So we're going to start out with a simple concept of, can you treat that child? Do you have consent to treat that child? A little medical legal. And just like adults, if it's life or limb, treat. You don't need consent. Easy. The next thing is, do you have to inform? And different states have different laws regarding whether you have to inform. Almost universally, as far as I know, if you're suspecting child abuse, you have a duty to inform. You can breach confidentiality. And then there are other things like pregnancy, access to mental health, STIs, that are state-to-state dependent. And then the final thing on this first slide on, do you have to consent to treat the minor? Do you have to treat to their parent or caregiver, the person who can provide you consent? You can have something called an emancipated minor. And you can be emancipated as a child and make your own decisions. Now, a lot of this stuff originally came from Hollywood and child actors who wanted to break an association with their parents so they could make their own business decisions. But it also involves health care. And so an emancipated minor can be if you're married. And I just did a Google search, and there are some states where you can get married at age 14, 15, 16. So you could have a 15-year-old who's married. You don't have to ask their parents to consent to treat them. They can consent for themselves. They've been emancipated. Now, another thing is, if you're a member of the armed forces, if you can sign up and serve and die for your country, you can decide your own health care, right? The final one's a bit trickier. Now, I usually poll the audience to see if there's a case report. But apparently, if you're a self-supporting child living on your own and not in the basement of my house, I have 3 kids, 2 have moved back in university. If you're emancipated and out there living on your own, you can make your own decisions. I think they should flip that around and say, if you're still 30 and living in your parents' basement, can you make your own decisions? Because your mom's still doing the laundry, right? So that's the emancipated minor thing. All right, let's start with inconsolable crying child. All right, because what do children do? They cry, they eat, they poop, right? They cry, eat, poop, and sleep. That's basically it when they're really little. That's their whole repertoire. So we're going to talk about crying, but crying is a normal behavior, especially if that's the only way you can communicate. I'm hungry, cry. I'm sad, cry. I'm tired, sad. I hurt, cry. This is inconsolable crying. This is crying that you can't settle, that you can't calm down, that you can't soothe. And so inconsolable crying can come from a number of different situations. The first one we put down there is colic, intestinal colic. We have no idea if it's coming from the intestines, but we call it intestinal colic. And this is defined as children inconsolably crying. You can't calm them down for 3 hours a day. Wow. For more than 3 days a week for 3 weeks. Wow. You can see how exhausting that is. We have 3 children. One of our children had colic, and it is exhausting to have a child that you can't calm down. Now, the presentation is usually they turn into this like screaming devil child, right? Cry, cry, cry. They look like they're in so much pain, and then all of a sudden it's gone. And they're back to being this beautiful child that you brought into this world. And then they start again. So it's colicky in nature and goes back and forth. Usually they pull their knees up, pull their arms up, cry, and then they're fine. Now, it says normal labs and physical exam. We really don't need to do laboratory tests usually on a well-appearing child in between these colicky episodes. It's a diagnosis of exclusion. I've got those red things in there because those are the highlights, but it can be a risk for abuse, right? So if you've got a child that's inconsolably crying and it's going on for hours, days, weeks, potentially months, you can see how that could be a risk factor for abuse. Do you know who the person is most likely to be the abuser? The mother's boyfriend, right, who's tired of this child crying. So it is a red flag, so provide support there. There is lots of different remedies for inconsolable crying due to intestinal colic, and if there are lots of treatments for something, what does that mean? Nothing works, right? It's almost like if you walk into any pharmacy and you go to the cough aisle, how many bottles of different kinds of cough syrup do you see? Hundreds. Why? Because nothing really works well. Same thing with intestinal colic. All right, so some other causes, trauma, of course, right? Soft tissue and fractures. This is a difficult one to pick up sometimes. Strangulation of a digit, or the penis. You need to look under the diaper, and that's a key concept to this, is you need to look under the diaper. Sometimes you won't find the problem. But you can get a hair tourniquet, right, around the fingers and toes, and so if you have an inconsolable crying child, you actually have to look at all 5 fingers on both sides and all 10 toes, and then take the diaper down to look for that hair tourniquet. Because that mother with the longer hair might be sitting there soothing that child who's inconsolably crying from colic or something, and they get a hair tourniquet, and it can strangulate the digit. Now, the treatment is a depiling agent, or you can take a scalpel and you need to cut down to the bone, because these thin little things can really cause a ligature there. The only side of that I wouldn't say, to caution you, is if you have a hair tourniquet around the penis, don't cut down to the bone. That's a separate category of that's called a moil, a circumcision. Not that there's a medical indication for circumcision, but you actually shouldn't cut down. You use a depiling agent to get rid of that hair tourniquet. Infections, of course, can cause this. Again, look under the diaper. Diaper rash. Has anybody ever pulled back the diaper and go, oh my God? You can see why the child's crying, right? Everything from the belt to the thigh is just covered in diaper rash, right? That would be very painful for the child. So look under it. Obviously, a urinary tract infection, other infections. And then we've got a whole bunch of surgical conditions there, incarcerated hernia, testicular torsion. They all say, look under the diaper. Now, intussusception, you're not going to find that on the diaper. You're going to find that on the abdominal exam. But look under the diaper. It's usually omission, not commission. It's because we didn't look. And parents love it. When you bring little Johnny in and you show an interest and you undress them, you give them the show. I remember Rick Bucata teaching me this. They came for the show. That parent and caregiver came for the show. You undress them. You put the stethoscope on. You listen. I don't know what you're thinking about. I don't know, that heart rate's going 120. I really can't see an S2, right? But you've got to show them that you care. So you undress them and check them out. I'm just going to give them a good head-to-toe check. It shouldn't take that long. They're only this big when they're little, right? All right, so rapid breathing in the neonate. That's the inconsolable crying. Now, rapid breathing in the neonate, we need to respect breathing in children because while adults go from cardiac arrest or a cardiac problem, children arrest more often due to respiratory problems. So if you've got a tachypnic child, that is a real concern. And in a neonate, under 28 days, lots of things can cause rapid breathing, everything from infection to metabolic abnormalities to heart diseases, and we're going to go through some specific ones, and then neuromuscular diseases as well. So we'll go through some of those specific ones with regards to rapid breathing in the neonate in detail. Vomiting in an infant. When we're talking about vomiting, we're not talking spitting up the towel over the shoulder, pat, 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 oh, watch, it's a llama, it spits. We're talking about where they actually projectile vomit. They vomit aggressively. There are lots of different causes for it. One is what the AAP has rebranded now, abusive head trauma. It used to be called shaken baby syndrome, and you can see how doing this and shaking the child with maybe intestinal colic and somebody comes up and does this repeatedly, could cause vomiting. Children can vomit because they have an infection, and it doesn't have to be a GI infection. It can be respiratory, it can be a UTI. Some children, just when they get sick, they throw up. Hepatobiliary disease, you should notice jaundice if that's the case. Inborn errors of metabolism. I'm not going to show you all these, like different pathways and stuff. Most inborn errors of metabolism, right, are usually acidotic and hypoglycemic. Acidotic and hypoglycemic. Malrotation of the gut, if you spin your gut around and twist it, it's a conveyor belt, and if everything is still going in, or you're just making saliva and it's got nowhere to go, it has to come out the other end, come back at you. So malrotation of the gut. Pyloric stenosis, you guys should recognize this. This is the child that's doing well as an infant, and neonate, an infant is doing well, and then all of a sudden they start falling off the growth curve, not thriving, losing weight, and you feel that little bump there, and then you get out your bedside ultrasound and you go, aha, pyloric stenosis in this little boy, and it's usually more boys. And then intussusception. Here's a little picture of the malrotation of the gut. The large colon, right? The large bowel is pretty fixed, but that small bowel can twist around on itself, and you can get these malrotations and cause intussusception and various things. Now, from vomiting to diarrhea, again, infectious causes diarrhea. And if we dichotomize it, viruses usually happen in the winter, and in the stomach, in the summer, it's more likely to be bacterial. So in the winter, it classically was rotavirus, but we're vaccinating against that now. We're immunizing children against that, so we're not seeing as much in the winter with rotavirus. Now in the summer with bacterial infections, some key ones are Shigella. And Shigella can cause a toxin that will cause not only bloody diarrhea and fever, but if they're seizing. If you've got a child that presents with diarrhea, fever, the diarrhea is bloody, and they have a seizure, you should be thinking Shigella. So if they gave you a question on the exam and said, you've got this 14-month-old, they're off to the park in the summer and started vomiting, and then all of a sudden got diarrhea, and then had bloody diarrhea, came in with a fever, and they seized in the department. What's the most likely organism? They're trying to tease out, do you know that this is probably Shigella? Salmonella can also give you bloody diarrhea, but doesn't typically give you the seizures. Now, you can get seizures like febrile seizures because both of these conditions have fever, but the classic is Shigella to give you that triad of fever, bloody diarrhea, and seizure. And it's interesting, when you see parents come in, it's changing a bit now that we all have smartphones with cameras on it, but for the longest time, parents used to always come running in, right? They've had the diaper bag and they've got all the setup there, and then they pull out this gift for you to show, right? And it's a little Tickle Me Elmo diaper, right? And they unpack it. The Velcro straps come off. They unfold it, and they show you crap. They want you to see it. And it's like, I've seen crap before. But it's bloody crap. And so they saved it just for you. Now, they want to show you. Now, you can get some information out of that. So if you've got streaking on the outside, right, you're going to be thinking, okay, is this an anal fissure or something like that? If it's all marbled or it's just complete watery blood, that tells you something else. You might be thinking, okay, intussusception is more likely because there's no well-formed stool there. So there is a reason to show you that. But I must admit, I like it now that everybody has a smartphone and they just take a picture and go like this. I want to show you what the poop looks like. Johnny made boom boom. Take a look, right? All right, so other things that can cause diarrhea: overfeeding, the bambino no eat, abnormalities, anatomical, intussusception. And again, we will go into intussusception a little bit more. Inflammatory disorders, malabsorption disorders. You can have the first presentation of an inflammatory bowel disease and Crohn's. Crohn's can be anywhere from the mouth to the anus. Usually presents later in life, sort of teenagers, early 20s, has a bimodal distribution, then up into the 50s. Immunodeficiencies. Oh, and then there's the iatrogenic ones. We gave it to them. It's called clavulin, right? Amoxicillin plus diarrhea. Antibiotics associated one. And then secondary lactate deficiencies as well. And so you get this stuff, this lactate fermenting in your gut, and it gives you a diarrhea. Blood in the infant's stool. The leading cause is actually allergic colitis due to cow's milk or soy intolerance. But again, like I said, if you look at the stool, you could see anal fissures for the streaking on the outside, and then you examine the child. They could be temporarily lactose intolerant. Intussusception is the woot, woot, don't want to miss that one, right? Salmonella or Shigella, right, especially in the summer. And remember, Shigella seizures. And then there's some other theories there. If you have one bloody bowel movement as a child, you get a mulligan, you can write that off if the child looks well. If the child doesn't look well, you're not saying, oh, it's okay. But if the child looks well, they can have a bloody diarrhea bowel movement. That's okay, but not persistent. This one is serious, so you don't write this off. This is necrotizing enteritis. And this happens usually in the first week of life. And we're not sure why it happens, but they desquamate and they just slough off their bowel, their internal bowel wall. And they just necrotize it, and it is a surgical emergency. This is an admission, antibiotics, and see a surgeon. Really high mortality rate. About a quarter of these infants, these neonates, will die because it's usually, again, in the first 28 days of life, usually within the first week. We don't know what causes it. We, of course, say maybe there's a viral component, it's idiopathic. There are things that are associated with the increased risk of having that. Prematurity is one of them. And so if they give you a case, they say we have a premature child that was born at 34 weeks, presents on the 7th day and has this bloody diarrhea and looks unwell, they're trying to tell you that this is necrotizing enteritis, and they want you to recognize that that is an emergency for an admission, surgical consult, and broad-spectrum antibiotics. The imaging test looks like this. Now, when you see this image, it's like, well, isn't it just out of focus? But that's the point. It looks out of focus because where the two bowels sort of slink past each other, you get this fuzziness, this thickness, and it's hard to see. It doesn't have clear defined lines. You don't see the Hofstra lines. And so if they give you something like that, it's not a bad reprint. It's not they print it, the computer's fuzzy. You can't sit there and go like this to make it bigger. It's actually they're trying to tell you that the bowel wall is inflamed and they're suffering from necrotizing enteritis or enterocolitis. All right, so neonatal jaundice, they're usually trying to pick up the serious conditions. They want you to know that so you don't miss serious life-threatening stuff. And they also want to talk about the most common things. And the most common cause of readmission for a neonate, in other words, in the first 28 days of life, after birth, the most common cause for readmission to hospital is neonatal jaundice. Most of it's physiologic jaundice. It's just due to hemolysis from the red blood cells, and it's fine. This too shall pass. It usually peaks in the first couple of days of life and then fades, right? We've all seen that. Sepsis-related jaundice, if the child looks sick, they look septic, that's different. That's not neonatal jaundice coming from a physiologic reason. And then there's breast milk jaundice as well. And if you want to figure out how to tell the difference between the two, the physiologic jaundice, the child looks well, they were just delivered, and it's 2 to 3 days out, maybe waiting for the breastfeeding milk to come in, those types of things. The child looks at jaundice, they look well, they get better. Sepsis, they look sick, and it can happen at any time. Breast milk jaundice usually happens at the 2 to 3 week mark. The 2 to 3 week mark, and it's due to some of the enzymes in the milk that's preventing the child from processing all that red blood cells, and they get jaundice, and the treatment is just switching from breast milk to bottle milk, and it goes away. Now, the AAP has some guidelines with regards to when you start light therapy. I have to admit, I do not memorize these. If they come in, I look it up. But the real key in big, red, and bold there is if you have direct, conjugated, it's gone through the liver, and now you have high bilirubin, but it's conjugated, it's gone through the liver, you have an outflow obstruction. This is serious. Your body's going to continue to process all of that and continue to increase the bilirubin, and that's going to lead to worsening jaundice because you have an outflow obstruction of some kind in the biliary tree, and that needs to be addressed surgically because it can become a neurotoxin. And so that's the red flag. If you have conjugated, okay, conjugated or direct high bili. Then intussusception. Now, intussusception is the most common cause of a bowel obstruction right, in early months to years of child's life, and it's the second most common reason they go for an acute abdominal surgery after appendicitis. And where does it hit? The right lower quadrant. And so usually. So when I see a child, right, who's complaining of abdominal pain, everybody's thinking about appendicitis because we know that. So I'm always thinking of, could this be intussusception? And I'm feeling that right lower quadrant because you get this cylindrical mass up in the right lower quadrant. And because you get peristalsis every 20 minutes or so, the child will look like intestinal colic where they'll get really a lot of pain and be upset, and then they're calm and fine in between attacks, but you'll feel a mass on physical exam. And I'm always thinking, could this be intussusception? Because that's the one I'm going to miss. I'm not going to miss the appendicitis because everybody's thinking, oh, could it be Johnny's appendix, right? So you're looking for that. Ultrasound is the best, I guess, diagnostic modality to identify this. So I've got a picture of a CT scan. Yep. So I've done that 3 times now, right? There it is. Yep. It's got a positive arrow sign, so that always helps me. But ultrasound is the way to go with this, and especially with bedside ultrasound. This is one of the easy exams to do. The children are usually thin, right? They don't have a lot of adipose tissue, and you can get there and examine. It's not a big space to examine as well, and you're usually up and down that right ascending colon looking for a specific sign. It talks about the sudden pain and the relief between things and this vertical oriented mass. So there's the CT scan. Okay, fine, it's got a positive arrow sign. But there is the ultrasound. Can you guys see that, though? You don't even need an arrow, do you? Now, people refer to this as the Cinnabon sign or Cinnabon sign. You know, I don't think that looks that sweet. I call it the radar sign. And if I see that, it looks like a radar screen to me, and I'm like, woot, 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 intussusception until I prove otherwise, especially if you've got that child. It's in the right age category, 2 years old, previously doing well, pain here, I feel a mass, they're vomiting, it may have bloody diarrhea, but that's a late finding. It'd be nice to diagnose it before then. And I put on my ultrasound probe, and I see a radar sign, my radar is going off, and that's a surgical referral. All right, that's it for that section. The next is on bruise, or bruise, depending on what you want to pronounce the E or not. So bruise. So we're going to go through bruise. Now, if you've been writing this exam every 10 years, the terminology sometimes switches. And so since the last exam, this one has switched. In 2016, the AAP changed the name from ALTI to, I guess we should just call it BRUI if it's ALTI, BRUI. So they changed it from ALTI to BRUI. They rebranded it, right? It's the same condition. So what does ALTI stand for, right? Apparent life-threatening event. So how do you think that went over? You know, with the parents coming in, oh my God, they turned blue and stopped bleeding, and you go, yeah, I've checked Sally out. Apparently it was just a life-threatening event. You can go home now. They're like, can I see a real doctor? Right? And so, you know, you'd have to tell them the diagnosis. I think they had an ALTI. Oh, what's an ALTI stand for? Well, apparently they had a life-threatening event. Bye-bye now. So they changed it to BRU, and that's a brief, resolved, unexplained event. So it's brief, it's gone. Yeah, we're not sure what it is, but they look fine, as opposed to saying life-threatening in there. So they rebranded it. It's the same thing. So the definition is it's a resolved event. They shouldn't be having it in front of you. The child must be less than 1 year of age, and it must last than 1 minute. And I'm sure, you know, I'm an EBM guy. There's nobody out there going, all right, and go. Johnny's blue. 48, 49, 50. It's a brew, right? Oh, no, they went 61 seconds, so it's not. You know, it's not that. They just want to say that it's brief. And if you've ever had a child who's had a brew who's stopped breathing, right? You know, children like neonates and infants can like have 20-second pauses. Try holding your breath for 20 seconds while your newborn doesn't breathe for 20 seconds. And see how long it takes you to freak out. And also time and space become one, right? And it's our perception of time. So they just want to know that it's a brief event. It's not a long-lasting event. And then they have things like, okay, so what was their color? Were they cyanotic or pallor, right? So they have to have that component. Absent, decreased, or irregular breathing. So was it or just slow or absent breathing? Muscle tone. Did they get floppy So hypotonia, or did they get stiff? Now, if they have a seizure, right, where you get a clonic-tonic seizure, that's not a brief, resolved, unexplained event. You have an explanation if they have a tonic-clonic seizure, all right? Altered level of consciousness is part of it, and no other explanation, and that's the key. So if they have no other explanation, if you have a child who's 4 years old, who has otitis media, and who has a fever and seizes for a febrile seizure, that's not a BRU. That's a febrile seizure. It doesn't fit in this box. There's high-risk categories and low-risk categories, and that's how they risk stratify them for management. So for high-risk categories, smaller children, and what I mean by smaller children is they were premature and they're young. So they're under 2 months of age, they were premature, and they had more than one event. You're like, I'm taking more attention, I'm giving more attention to that child. We're doing more of a workup, we're all in on that child, we want to make sure they're okay. But if they're low risk, so they're over 2 months of age, they weren't premature, it's their first BRUI, the duration was short. It says that they didn't have CPR applied by a trained medical professional, because we've seen people who've done CPR on people that are awake, right? And so it's not, oh my God, you know, like that's all they know. Stop, drop, and start going, staying alive, and the person's like, I'm alive, all right? And so they say, they make that definition that has to be a trained person. So if it's a lay person doing CPR, they don't consider that part of that factor in the low risk category. So for the high risk, like I said, you're all in Vegas, right? Full evaluation, consider admission or observing for a period of time. Now, if they're low risk, though, educate the parents. Tell them about a BRU. Do some SDM, that stands for shared decision making, and as a public health measure, talk about CPR. Okay. You may do pertussis testing because, of course, children can cough, 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 whoop, and then look like a BRU. You can get an ECG on these children, if you'd like, and some monitoring for a brief period of time and reassessment, if they're low risk. But you don't have to go CBC lights, BUN, creatinine. You don't have to be all in with all the testing, right? Looking for things, getting an EEG, getting a chest x-ray, doing GERD, home monitoring, right? There was a great Gomer blog. I don't know if you know that. It's sort of like, Gomer blog is like the Onion of political satire, but for medical satire. And they said that they were making a joke about ACOG, the American College of Obstetricians and Gynecologists, were coming out with a new APGAR score. And it was called the APGAR T. And the APGAR T would mean at 1 minute and 5 minutes, they would get a troponin. Just so every child in America could get used to over-testing, right? And so you don't need to do this. If a child has a BRU and they're low risk, you don't need a troponin on them. You don't need a D-dimer. You don't need a pro-BNP, all right? You don't need to get viral testing, urinalysis, glucometers, and all this kind of thing. And you don't need to admit them just for observation if they're low risk. All right, so that's the BRUI. SIDS is different. It's the most common cause of death after the neonatal period and before 1 year of age. Most common when they're little, 2 to 4 months there. All right, there's some stuff in there with regards to no seasonal peak, increase in certain ethnicities, Native Americans, African Americans. Multiple causes are suspected, which means we don't know what causes this, but there are risk factors, right? There's risk factors associated with this. So if you have a sibling that died of SIDS, that puts you at risk factor. If there's multiple children, if it's a younger mother, if there's drug abuse in the home, all of these things can put you at higher risk, but we still don't know what the cause of SIDS is. The key take-home message about SIDS is that the child is supposed to sleep on their back, right? In this very sterile environment. I've mentioned that we have 3 children. I don't know how they ended up into adulthood, because at that point in time, we had every little beanie baby in their bassinet. We had little pillows everywhere. We had a mobile that could fall down and choke them. I mean, we pretty much did everything you're not supposed to do. What you're supposed to do is have them on their back, not sleep with you in your own bed, not sleep with their siblings in their bed. It's just this environment where they can't get wrapped up in a sheet and stuff like that. Have them lie on their back. That's it. All right, so we're going to move from SIDS to pneumonia. The pneumonia section, lungs are the most common site of infection. So when we talk about infections, we're usually talking, okay, it's going to be airway, right, for infections, or urinary, right? A urinary tract infection. Number 1 is in the respiratory system. And group B strep, group B strep in neonates. So under 28 days, group B strep. Why do we test every pregnant woman for group B strep? Because we're trying to prevent group B strep. Are you getting the message here about group B strep? Got it? Okay. Group B strep. We treat women when they're pregnant for group B strep. All right. So other common causes, H. flu, M. catarrhalis, chlamydia is down there as well. If they get pneumonia, you should be able to see this child breathing quicker, having a fever, indrawing, accessory muscle use, retraction, decreased appetite. We've just highlighted there in chlamydia that the can be afebrile and tachypnic, but they get this little staccato cough and get conjunctivitis and can be hyperinflated with the but they're afebrile. And then viral, we're immunizing a lot of these children about RSV. There's all these other viruses that they can get. We've got down there that, things like pertussis and stuff like that. We're seeing now cases of rectal prolapse. So the child coughs so hard, they blow out their back end. So they may come in saying, they've got a cold, but that's not why we're here. And you have to take the diaper off, and you take the diaper off, and they've got a rectal prolapse. If you see rectal prolapse in a child that has some kind of URI symptoms, coughing and things, you should be thinking pertussis, especially in populations that haven't been immunized. And there are out there. One of my favorite t-shirts to wear to medical conferences is I got this wonderful t-shirt. I walked around in Vegas last time I was here, and it says, "Vaccines cause adults," right? It's either a conversation starter or stopper. And those with dyslexia go, "No, it causes autism." Oh, no, okay. So, vaccination history is really important, especially if you see a rectal prolapse. So they can try to throw you and put up a picture of a child's rectum, and it shows rectal prolapse, and they'll say, "What's the most likely organism?" And you're like, "What?" Pertussis is what they're trying to get at. Bronchiolitis. In Canada, we're experts at this. We have 2 seasons, August and bronchiolitis. So we have massive amounts of bronchiolitis. It's supportive management, keep them well hydrated, supplemental oxygen only if they're hypoxic and things like that. It can be associated with some apnea and stuff. There were some really cool experiments that they did up in Canada at the Hospital for Sick Kids, and Rick Bucata says is that down the street from the Hospital for Well Children. But Sick Kids Hospital in Toronto did this really sneaky study where they put on a SAT monitor, and they dialed it, they changed it, they dialed it up, and so it would read 3 points higher. Now, I think the exclusion criteria was if the real SAT monitor said they were in their 80s or below, or they didn't get into the study, right? But we know that physicians make decisions based on objective data, like what's their SAT? Oh, they're 99, they can go home, kind of thing. So what they did was they rigged these SAT monitors to read 3 higher sometimes. And so if the child may have had a SAT of 90 and it would read 93. They may have said 92 and it read 95. Right? So there were some children that were more hypoxic than the other children that had the regular SAT monitor. And you were more likely to send those children home. What was the end result? No difference in outcome with bronchiolitis with children that had lower SATs. They got even sneakier. They sent parents home with a SAT monitor that didn't show them what the SAT was, right? It was like a Holter monitor for SATs, right? And there were periods of those children with bronchiolitis, extended periods, minutes, multiple episodes where they were SATing in the 70s, and they did well. Right? So bronchiolitis is about supportive management. Now, if you have a child that's SATing in the 70s or 80s, please go ahead and give them supplemental oxygen and admit them. But these children are really robust with bronchiolitis. Pertussis and whooping cough. So we talked a little bit about that, about the rectal prolapse and stuff. We're seeing more of it due to lack of immunization, and also the immunization isn't great. Right? And what I mean is, like hepatitis B immunization works really well, right? You're up in the high 90s with just the first shot. With pertussis, it doesn't work as well. It's in the 80s for seroconversion, and so you don't have a lot of protection. So we're relying on a lot of herd immunity for that. And of course, if you're under 2 months of age, you haven't been immunized yet. And so now what they're doing is with every pregnant woman, what do they get during their pregnancy? They get pertussis vaccination now. They're getting a tetanus shot with pertussis in it every single pregnancy. So if they have 5 pregnancies in a row, 5 years in a row. Every year they're pregnant, they're getting 5 shots every single time they're pregnant, just to protect that unborn child and during their first few months of life with passive immunity from the mother to prevent this. And it's adults that are the reservoir, and it's called the 100-day cough because adults, we've got bigger airways, so we don't go cough, 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 and have the whoop. We just go cough, 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 cough. One of the sure signs that they have pertussis, or whooping cough in an adult, is you count out how many Z-packs they've had, or Z-packs you call them, sorry, there's my Canadian. How many Z-packs they've had in the last 3 months. If they just keep going back to another doctor and getting another one, or now they're on their 3rd antibiotic and it's a respiratory fluoroquinolone, it's probably pertussis, right? It's going to last 100 days. Complications, mucus plugging, increased thoracic pressure, rectal prolapse, there it is, and a ruptured diaphragm or hernia. So these are life-threatening illnesses in children, especially if they haven't been able to be immunized. Treatment goal is obviously to get herd immunity, and then you treat with antibiotics. All right, so from pertussis to febrile seizure, this can be another fair game question on the exam. Febrile seizures. So a simple febrile seizure, it has to be associated with a fever. If you don't have a fever with a febrile seizure, it's not a febrile seizure. We call that a seizure. All right? It's usually age 6 months to 6 years of age, so that a brief, short, it's not greater than 5 minutes. All right? It's not the classic status epilepticus that's 20 minutes in length or multiple seizures without recovery in between. It's usually less than 5 minutes. It's brief. It doesn't have a big postictal state. You usually don't find another cause for this other than the fact that they have a fever, and they usually have some kind of URI or something like that. It tends to occur in families, so it's about a rule of a thirds. So there's about a third of chance somebody in the family has it, a third chance that they've had a febrile seizure before, and a third chance that they will get another febrile seizure with their next febrile illness. Compare that to a complex seizure, longer than 15 minutes. Oh, that's complex, right? If you've got somebody that's seizing for 15 or 20 minutes, I'm putting that in the status epilepticus category, all right? We're moving on from the benzos to second-line and third-line agents for that. Certainly if they're at the extremes of age, so we shouldn't be seeing febrile seizures in 2-month-old and in 10-year-olds. So if they're outside that 6 months to 6 years of age, that's complex. That needs more attention and more workup as opposed to reassurance. All right, so causes of seizure amenable to a specific treatment. I've seen this, and my father-in-law is a pediatrician. He's the one that clued me in on this. I had a child that had gastroenteritis. So they had nausea and vomiting, nausea and vomiting, nausea and vomiting, and then went to bed. And they slept for, 12 hours. They had this long, prolonged sleep. And then when they got up first thing in the morning, they seized. And I'm like, well, that's weird. And they don't have a fever. Is it gastroenteritis? They didn't have bloody diarrhea. Is it Shigella? What could it be? And then they were so hypoglycemic. It's because some children don't have a lot of glycogen stored, and so their sugar level drops to a point, and all they need is a little sugar. So you give them some 10% dextrose. So we've got to watch that with gastroenteritis in pediatrics. Hyponatremia, so I have given sugar to children that are seizing. I have never given hypertonic saline. Has anybody given hypertonic saline to a seizing child? I've given it to a seizing adult. Somebody's got a sodium of 111 and they start seizing, they're getting hypertonic saline. But I've never given hypertonic saline to a child. No? Okay. How about hypocalcemia? Haven't seen that. But you give calcium gluconate. Hypomag, give mag sulfate. Right? I've given mag sulfate to seizing pregnant women, right? I've given that, and I've given it to Torsade, but I've never given it to a seizing child with hypoglycemia. Now, somebody may have seen INH ingestion, has somebody, in a child that comes in seizing, and there's the anecdote for that. All right, pediatric hydrocephalus. So increased CSF volume, usually associated with increased CSF pressure. There can be a variety of causes for this as well. Congenital intrauterine infections, of course, congenital abnormalities, you can get meningitis, bleeds, but you can have a non-communicating blockage between the ventricles and subarachnoid hemorrhage, and that's got the quote, a failure to communicate. I told you yesterday I give 80s movies to my students so that they get my jokes, and I inherited these slides and this lecture from Rick Bucata when he brought me on faculty, and so this movie's not from the 80s, so I had no idea who this was. No idea. What we got here, boy, is a failure to communicate or something like that. I didn't know what that movie was. Don't shout it out, because if you know, I'll give you a prize after. I didn't know. I had to watch the movie. It's a great movie, by the way. Excellent movie. Paul Newman, right? At least I know that. Paul Newman. All right? But you can get that. Communicating hydrocephalus impaired absorption of the CSF, and so that can cause increased pressure. And so here's one of the causes. You see these large-headed child with big fontanelles, dilated scalp veins going like this, and they call it a crackpot. You tap on the head like that, vomiting, lethargy, but that's sixth nerve palsy. Remember the sixth nerve, and you get that lateral rectus involvement? If you get a tip-off in a case talking about a sixth nerve palsy, they're trying to cue you into this or something like that. All right, and you get the CT scan and you show those increased ventricle sizes. All right, pediatric hydrocephalus. Now the next slide isn't pediatrics. This is, this one is, sorry, the very next one. Pediatric hydrocephalus, always somebody in the audience that's drained one of these shunts, put a needle in there for the child that's come in. Always in the audience. I've never done this, but they put a shunt in, they place a shunt in, it can get blocked, and you need to relieve and drain that pressure, so it's simple of just actually aspirating the shunt. Anyways, if you're worried about infection, we have this, if it's dichotomized, if it's early on since you've got the shunt placed in that child, it's more likely to be a skin bacteria, a skin contaminant, something like that. And if it's later, it's the rest of the usual bugs, and they present with meningitis-like symptoms, but it's usually skin flora if it's in the first 6 months after the insertion. Has anybody tapped one of these? Yeah, there's always some. Oh. You have two labs, right? 2 Labradors? Oh, she's not even paying attention anymore. Yes, she has 2 Labradors. She's wearing a beautiful shirt with a chocolate lab on it. All right, idiopathic intracranial hypertension. That's the one I was talking about that's more of an adult situation. It's usually young women, a little bit larger in size. They don't get that increased ventricle size. They're increased in size, but the ventricles aren't increased in size. And they get this opening pressure. Tinnitus, like this is one of those cases when if you were here yesterday for Billy explaining, and they give this reading comprehension test of all these, this long paragraph, and they present a young woman and they say, and she's a little bit overweight and she has some tinnitus, and you're like, what are they getting at? And they're trying to give you some triad to tell you that they have this pseudotumor cerebri or idiopathic intracranial hypertension. And they talk about visual acuity and tinnitus and those types of things. That's what they're trying to get. You follow them with visual testing to make sure that they're doing okay. And then there's lots of different treatments down there, some of them that we're not going to do, fenestration and lumbar shunts and those types of things. It's a matter of recognizing this condition. But again, it's not so much pediatrics. And there's some pictures of some papilledema for you. You've got the normal retina in the center that's more yellow-orangey color, and then the ones around it, all of those ones around that center one at the bottom, all the ones around that are abnormal, showing that fuzzy haziness and that cup-to-disc ratio for papilledema. Now, you may not have seen it. You go in there with your light, and you're looking in there, and what's the pupil automatically do? And you're sitting there going, okay, so I often, if you're dilating the eyes, you'll see this kind of retina, but unless you're dilating, it'll be difficult to get these kinds of images. So we show you here. All right, moving on to meningitis in children. If they're little children or if they're older children. So in the first 2 months of life, we're worried about where they came from. So again, strep B, right? Strep B, group B strep. Why do we test women for group B strep? Right? Pregnant women for group B strep. It's because we're going to treat this. This can be very serious for the child. So group B strep, meningitis. All right? E. coli, because of the birth canal and where this baby has come from. And then listeria. And listeria is much less common, but ampicillin must be given to the antibiotic treatment regimen to be able to cover listeria. Now, once they get over 2 months, the bugs change, and so we'll see strep pneumo, but also Neisseria meningitis. Now, the highest mortality rate is for the strep pneumo. So strep pneumo is the highest cause of mortality. We've got a red flag there about ceftriaxone and neonates or calcium-containing IV fluids. I think that's into the weeds maybe a bit. The question can come up, do we give steroids to these children? My typical thing is if I think a child has meningitis, I'm throwing on the antibiotics and I'm letting the admitting team decide on steroids because the data isn't clear. There is specific types of causes of meningitis, like H. flu, that can have better outcomes, but at the time where I'm giving the child the antibiotics, I don't know what bug they have. And the other thing was a subgroup analysis in a Cochrane review saying, children in Western countries with decreased hearing. So a subgroup analysis is hypothesis generating for me, but it's not convincing enough for me to incorporate it into my routine practice. So I don't give steroids to every child with meningitis. I leave it up to the admitting team to decide. And there's just a nice cloudy tap. All right, so now we're going to get into the heart and talk about tetralogy of Fallot. And, yesterday when I was listening to some of the other lecturers going, myasthenia gravis, it's always on there, right? Pediatrics, what's going to be on there of rare conditions that you probably won't see? Tetralogy, right? What else? Kawasaki's, right? They're always got to ask something about Kawasaki's, it seemed. It's sort of the Eaton-Lambert of pediatrics. They ask those questions. So tetralogy is one of the ones they want you to know about. It's the most common cause of a congenital shunt. And this is the one part where I get to throw on my full Canadian accent. You ready for this? On the x-ray, they get a boot-shaped heart. Didn't that sound really Canadian? I could say a boot all day. How's it going? You get decreased pulmonary vasculature markings. And if you understand the anatomy of the 4 different things that are going wrong in this congenital abnormality, you understand why the heart expands to look like a boot and why you don't get vascular markings in the periphery for this condition. They get TET spells where they get, cyanosis, short of breath, upset, syncope, and it increases a right to left shunt, because that's what this is. It's a right to left shunt. Now, if you put blow-by oxygen on, if you understand the anatomy, and we'll show you some pictures, it's not going to work, right? If you have a heart that's taking in blood, right, and you have a garage door open between the right and left ventricle, and you have a cocktail straw to go from the right ventricle to the lungs to get oxygenated, where's the blood going to go? It's going to go through this big garage door over to the left ventricle and get pumped out to the body. And so you're not going to get blood going up and out to the heart, so you're not going to see that vascular markings, right? And if you put blow-by oxygen, you're going to provide more oxygen to blood that's not going to get oxygenated. It's not going to help, right? You try to keep these children relaxed and calm. They bring their knees up to their chest. They snuggle into their caregiver, and that can help because it increases peripheral vascular resistance and can decrease that right to left shunt. And so the knees to the chest position increases that systemic vascular resistance. They've got things like morphine, and again, that's probably just to calm the child down. Bicarb, propranolol. I've never given ketamine to a child for this. I've given ketamine to children all the time, but not for tetralogy. And again, maybe that's just to calm them down. I'm a bit concerned about giving ketamine because it usually increases their blood pressure and increases their heart rate. So there's the anatomy. And if you understand the anatomy, you get this big right ventricle, right? That's number 1. Right? You got this garage door for a right to left shunt. So you have this big VSD, and the blood wants to go from the blue side to the red side through that big hole in the heart, that VSD, where that circle is. And then look at that pulmonary artery. Look at how stenotic that is. It's this tight little cocktail straw with an aortic arch going across it, pinching it off even further. So you have those 4 elements. The blood wants to flow from the right side to the left side and not go out to the lungs to get oxygenated. So providing extra oxygen doesn't help these children. And there's some images. And it's not like they're over-penetrated films. They're not. You just can't see the vascular markings because the vasculature is not engorged in any way. It's not being perfused enough to be picked up on a standard chest x-ray. And you see the heart that looks like a boot. I don't say a boot. All right. HIV in children, there's no way you're going to be HIV in children experts, just like the HIV portion of my hematology lecture. Just a couple of slides here to say that, it is a problem. There is an ascending or a transmission from mother to child that can be prevented using appropriate treatments. If the child does have it, it can cause growth retardation. And remember, it's connected to sexually transmitted infections. The febrile HIV positive child, the most common bacterial pathogens, Pneumocystis jirovecii, is the most common opportunistic infection. Just like adults, you treat them with trimethoprim sulfamethoxazole, or what you guys call Bactrim, steroids as well. And again, they get disproportionately short of breath and fatigued with PJP. All right, Kawasaki's disease. Come on, you've got to expect one of these questions on the exam. So an autoimmune vasculitis of the small and medium blood vessels. And what you have to have is a fever for 5 days. If you don't have a fever for 5 days, you can call it incomplete Kawasaki's. But a fever for 5 days is how you get into the algorithm of, is this Kawasaki's? And they have to have 4 out of the 5 cardinal signs. So it's a measles-like rash, which can be harder now because there is some measles going around. Also, they get conjunctivitis. Measles get conjunctivitis as well. They get the cracked lips and around the mouth. So it's different than the Koplik spots that you see with measles. All right? And then you get the hand and limb swelling, and you can slough off the hands. And then you get lymphadenopathy. So you have to have 4 out of the 5. They don't all present at once, and they don't go, they've got 4 or 5, or they have nothing. It can be a progression over the course of the illness, but they have to have 4 or at least 4 out of those things with a fever for 5 days to be considered Kawasaki's. Now, we've got some pictures there showing the desquamation of the hand, showing the cracked lips, showing the conjunctivitis there. All right? Myocarditis is the big risk factor, and coronary artery aneurysms, and we're trying to prevent those with treatment. And the treatment is IgG, right? IgG is the treatment for this. People have tried aspirin. The AHA has a recommendation saying, yeah, you can try it. It's reasonable, but it's a level C recommendation. And Cochrane has done a review, and they're sort of the organization that does these high-quality systematic reviews, and they're like, yeah, we don't have really good convincing evidence that ASA helps or aspirin helps. And so, again, IgG would be the answer, and I let the admitting team decide whether or not they're going to give ASA or not for these children. Kawasaki's. Okay, cystic fibrosis. So this is the most common lethal genetic disorder in Caucasians. So you think, if it's common or deadly, we should know this, right? So this is the most common and deadly genetic disorder in Caucasians. It's autosomal recessive, and it hits all the ductless glands. And so we know these children. We know about the sweat tests and the chest stuff they get, but there's other infections that they can get. They can present with intussusception. They get all this mucus plugging, and they get an intussusception. And so they could have a radar sign, a cinnamon bun sign on ultrasound, on bedside ultrasound, if they come in with bloody diarrhea, let's say. And so here are the problems that cystic fibrosis can hit. The sinuses get involved, the lungs get involved, the GI tract, gallbladder, lots of different ductless glands in the body that can be affected by cystic fibrosis. So the respiratory emergencies, you can see how they get cor pulmonale, hemoptysis, if they're getting cough, 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 pop a blood vessel, drop a lung, and go into respiratory failure. So I think we understand cystic fibrosis and the respiratory stuff, but we may forget some of the GI and other problems like the electrolyte abnormalities that can come with this, the intussusception that can come with this. My daughter growing up had a couple of friends, sisters, and they both had CF. Right? And so when they would come over for birthday parties and stuff, they had to take certain enzymes and stuff like that to help with their digestive system, and they were chronically, it seemed, on various antibiotics for that condition. All right, HSP, another one they usually like to ask, okay? So this is palpable purpura. So if they've got palpable purpura, you know that it's a vasculitis. If it's non-palpable, what is it? It's the platelets. They're not working well, or you don't have enough of them. So that's the dichotomous decision there. Is it palpable or not? If it's a palpable purpura, you're thinking HSP vasculitis in young children. Not in infants, but in young children. And they get it, the extensor surfaces are more likely to be involved. They can get renal involvement. You can see how the vasculitis could cause renal failure and things like that. And there are the tests there for that with regards to platelets, PT, and PTT. And there are some nice pictures to show you. I don't know how well they show up on the screen there, but showing the extensor surfaces, showing those purpura that when you feel them, they'll be palpable. Okay, from HSP to hemolytic uremic syndrome. This is acute renal failure associated with microangiopathic, small little, hemolytic, so they're going to be anemic, and low platelets, thrombocytopenia. And the cause is usually a Shiga toxin-producing E. coli 0157H7. All right? There are other bacteria and stuff that can do this. They get bloody diarrhea, bloody stools with HUS. Schistocytes will be seen on the smear. They usually have a normal PT, an INR, and fibrinogen, unlike DIC, which is the consumptive coagulopathy, which I talked about yesterday. And with DIC, usually the INR goes up, so that's the PT, and the fibrinogen level drops, and the platelets drop. It's a consumptive coagulopathy, and they both clot and bleed. All right, so it's similar to TTP, but it's the kidney involvement is the main problem. And so how I remember this, and there is just a pictures of where you can get it, improperly stored meats and stuff like that, certain sprouts and vegetables and stuff. You'll see these warnings from time to time on the news and saying, this has been recalled and stuff like that, or this restaurant chain has had an outbreak, and I didn't want to point out any one restaurant chain. A lot of the information that we have about this condition came from a town about a half an hour from where I live. About 10 years ago, they had a big outbreak of HUS. And it was like, well, how did that happen? How did they get E. coli into the whole community? And there's like thousands of people in this community. How did thousands of people get this? It wasn't a picnic. Like they didn't all go to picnic and have, the tainted potato salad or whatever it was. How do you think they got it? Water supply. Yeah, and so this is a farming community, and they're spraying with manure, and they have groundwater and well water and a municipal water system. So they had this big rain, and they have water chlorination plants that are supposed to be inspected on a regular basis. And this small town had these two brothers that were responsible for going around and maintaining the chlorinators on the municipal water supply, and apparently they weren't doing their job. And they were not necessarily always going and checking and filling out the logs, like it actually, attending to these things. And after a big rainstorm, you got all these things converging with a big rainstorm, recent fertilization, chlorinators not checked, and the whole community, everybody who drank water in that community got exposed to this infection. And there was a huge outbreak, and so there's a huge research center that was set up for this. And I remember this because of for the children, they're following them along because of the renal function and the downstream hypertension and stuff like that. Some of the other key messages they found with that was the children the people that were given antibiotics did worse. Right? And so if they treated this E. coli with antibiotics, they did worse. Now, it may be observational data. Well, it is observational data. But maybe the people that got antibiotics were worse, and that's why they got antibiotics, because the clinician was like, oh, my goodness, they're really bad. I better give them antibiotics, as opposed to it's the antibiotics caused further badness. But we don't routinely now give antibiotics for this condition. All right, speaking of fluids and tainted municipal water supplies, if you have a child and you're looking at how dehydrated they are, we go mild, moderate, severe, and we go under 5%, 5 to 10%, or greater than 10%, like that, and then we give 50 mils per kilogram, 100 mils per kilogram, and 150 mils per kilogram is what we calculate their deficit, to be, and so that's how we stratify them. A key point in this, and this may come up in the exam, is the AAP and the World Health Organization say oral rehydration is the way to go. We shouldn't be starting lines on all these children. oral rehydration is the way to go. And there was a study a couple of years ago comparing fancy electrolyte solutions to half-strength apple juice in a non-inferiority study design, and they found actually that half-strength apple juice plus fluids of choice were actually superior to giving them a fancy, expensive electrolyte solution. And if you think about it, if you offer a child something they want to drink when they're dehydrated, and these are mild to moderate dehydration children, these are not severe dehydration, you offer a child what they want to drink or something that they may not want to drink that tastes a bit, has anybody drank those electrolyte solutions, right? You give them what they want to drink, they're more likely to drink it. So if they're drinking the solution and they're dehydrated, they do better. And also this whole idea of brat diet has gone away. So if you grew up in the era of brat diet, that is no longer the recommendation. So if they throw on a question that says, after an episode of gastroenteritis, what should the child's dietary, they should go back to eating their usual, regular, healthy diet, right? Not specifically a brat diet. Severe dehydration, that's the 20 mils per kilogram over 20-minute bolus. Just remember that if you're doing that, if you're giving normal saline, and if they've had gastroenteritis, and that's why I told you the story of my pediatric father and the gastroenteritis and the seizure that morning. Quite often during my career, I phoned up my father-in-law for pediatric advice, and I always remember that. So if you're rehydrating a child who's had gastroenteritis, they could be hypoglycemic, and then you give them 20 mils per kilogram of normal saline, they're going to be more hypoglycemic. And so you've got to give them some sugar containing, so consider D5 saline. Oh, did I have something else on there? I can't remember. No, and that's the appropriate diet. So you give them an appropriate diet at the bottom. Okay, so how do you calculate how much fluids to give for maintenance fluid? So 100 mils per kilogram for the first 10 kilograms, 50 for the next 10, and 20 mils per kilogram for every kilogram over 20 kilograms. And so this is where there's math. I have to tell you, I don't do this in my head. I have an app for it. On the exam, you won't have an app. You won't have your smartwatch. You can't call a friend, and it's not, well, hopefully you can get it down to 50-50. But the thing is that these are the calculations, some of the basic calculations they can expect you to know. We generally avoid using sedative antiemetics. I mean, everybody's pretty much has moved to ondansetron now, it seemed. If you look at the graph of over time and use of ondansetron, when it came out and got pediatrics, it just went up like this, right? And having those ones that can dissolve under the tongue, the little 4 milligram tablets, and I break one in half and give them 2 milligrams there and a second 2 milligrams to go home, it's changed my practice in pediatrics with these vomiting children. We try to avoid the sedative ones. There are whole courses on ACLS for children. It's called PALS. We're not going to obviously cover that in a lecture like this. But when it comes to pediatric ACLS, some basic concepts is it's 2 joules per kilogram for defibrillation. Cardioversion, as you know, is a lower energy strength, and so it's 0.5 joules per kilogram. When you're intubating, cuffed or uncuffed, I'm almost always using cuff tubes because early in my career, I remember from my bad cases where I had a child that had an uncuffed tube that I had intubated. I had to transport them from a critical access hospital to the higher level of care, and they seized in the back of the ambulance. It wasn't a cuffed tube, and they turned their head, and I lost the tube, and then I had to re-intubate them in the back of an ambulance. Just as an FYI, that can be stress-invoking. And so you learn from that. And so now, I mean, that child's getting a cuff tube, and we're duct taping that head to the board, right? And so you don't have that happen again. ET tube size, I've got an app for it. There's formulas for it. I just use the app. There's the Broslow tape that you can use as well that gives you all that information for drug dosing and for tube sizes and things like that. Surgical crikes, it depends on which organization you follow, but they say not recommended in children under the age of 12. And the narrowest part of the airway is the cricoid cartilage. And then they've got the fluid bolus there, that's the recommendation, and it's 20 mils per kilogram, normal saline. Asystole is the most common arrest rhythm. Remember, children usually arrest from respiratory problems, so we don't see a lot of cardiac arrests. If they're braddying down, that is a bad sign. Epinephrine is the drug of choice in asystole, so it's an easy algorithm to remember. It's epi for asystole. Bradycardia, like I said, usually it's respiratory compromise, those hearts will go forever. And I've seen and resuscitated children that have been down for extended periods of time and got them back. The heart still beats, and that's why the child doesn't end up doing well, either neurologically or otherwise, but their hearts are strong, young, and healthy, and so they go for a very long time. So if you're getting a brady or an asystole, that is a huge danger sign there. And we do the ABCs, right? Whereas in adults, we do the CAB, right? We do circulation, airway, breathing. But in pediatrics, we're still at the ABCs because the airway is so important. Correct causes, PEA, hypovolemia, VFib and VTAC are rare. Think hyperkalemia if you get that, or hypothermia. You need to memorize this. No, I'm just kidding. I love throwing that. If you were here for Billy Mallon, that's a destabilizing slide. I'm just messing with you now. An acid-based blood graft diagram. It's almost up there with the coagulation cascade, which you do need to know. All right, and then APGAR score. I just throw this in because Virginia APGAR is a superhero of science, and I didn't know that her name was APGAR. I thought APGAR stood for, okay, so it's activity, pulse, grimace. That's what I thought APGAR was. No, it was Virginia APGAR, Dr. APGAR's last name, and she's a superhero of science. All right, neonatal resuscitation priorities. Dry, warm positioning, right? Suction and you're rubbing them, right? You ever seen, a newborn and, they're rubbing them with towels and they're stimulating them and they've got them under the heat grow lamps and stuff like that. Supplemental oxygen, bag, valve, mask, ventilation, chest compressions, intubation, epi's your drug of choice, all right, for neonatal resuscitation priorities. Again, this is a superficial coverage of these types of issues. And then we have a whole bunch of pediatric pearls. And so when I inherited this lecture, Rick said, if you've got enough time, go through the pediatric pearls that are there. If you don't have enough time because of lack of time within the course, they can review this in the airport on the way home. We do have a little time, so I'm going to pull out some of the highlights. But it's a list of 32 different pearls from the pediatric section. First of all, it's neonates and respiratory. You got to respect their system. How do they increase oxygenation and stuff? They don't increase by volume. They don't sit there and just expand their chest. It's usually respiratory rate. So they start going fast. And if you get a breathing rate of greater than 60, you should be worried. All right? That's an abnormal vital if they're huffing and puffing, if they're tachypnic. Newborn infants, right? They can have apneic spells. They can go 20 seconds, and it's very concerning, right? But it's still actually normal. But it's obviously very concerning for the parent to watch their child, especially if they're a preemie, have 20 seconds, right, of this with bradying down and getting cyanotic and getting poor tone. Sounds like a brewy in an otherwise well child. Bradycardia is almost always due to hypoxia there. Respiratory rate, again, greater than 60, and if they're grunting, nasal flaring and stuff like that, it's about the respiratory. That intercostal indrawing, that tracheal tug, that type of thing gets you worried. Fever of greater than 39 degrees in the presence of a UTI equals pyelo. Okay? 5 to 10% of them will have bacteremia. The incidence of bacteremia and sepsis in a febrile children 3 months of age or less, so this is early on, they may only have one immunization, is 2 to 3%. If they're ill-appearing or significant abnormality laboratories, they can be even higher rates. Now, if you have immunized children between 3 months, so they've had their first shot at age 2 months, and 36 months, almost the completion of their primary series, and a well-appearing but febrile child, their risk of bacteremia is less than 1%. Okay? It's unlikely. If you've got an older child, so greater than 3 months, they're out of that neonatal period, right? You know how we brought that number down. When I started, it was everybody under 3 months. That was the easy case. Child could come in 2 months and 29 days and had a fever, call peds. Now it's on to the next case, right? Then it dropped down to 2 months. Now they're trying to push it down to like 1 month, right? 1 month and a fever in a child. That's all in. But you can start doing some other stuff where you're not necessarily doing all the stuff in that 2 to 3 month range. The safest approach to febrile children less than 30 days that's the full on. That's still that under 1 month, that neonatal period. You're all in for those. The AAP has some recommendations about testing for UTIs in all febrile girls and uncircumcised boys less than 2 years of age if there's no apparent focus. So if you have a child that has a fever, you're thinking UTIs in girls and uncircumcised boys under the age of 2, and then 1 year of age in circumcised boys. Analgesics, this is for oral or topical. If no tympanic membrane perforation is an important part of treating otitis media, what we do is help alleviate pain and suffering. And so, of course, the antibiotics, the number needed to treat is somewhere around 17. You need to treat 17 children with acute otitis media so that they have less pain on day 2. Right? So it's going to take until day 2 for 1 out of 17 children to feel better clinically. So give them something for an antipyretic or an analgesic. And just with the antipyretic thing, the AAP says if you have a well child who has a fever, we should really emphasize treating the child, not the thermometer. If they're well, they're fine. If they're suffering and they're miserable because of the fever, of course give them an antipyretic. And another thing is that antipyretics don't prevent a repeat febrile seizure. There was a recent Japanese study that suggested that if you gave rectal antipyretics to children that had already received rectal benzodiazepines for their febrile seizures, you could prevent a recurrent febrile seizure in that febrile illness. But there was a lot of problems with that study, so I still stand by you don't need to, make a parent feel guilty that clearly they had a repeat febrile seizure in their next illness because you weren't on top of their fever enough, right? It doesn't reduce the incidence of recurrent febrile seizure for the next febrile illness. Some other pearls there is one is that x-rays can confirm a foreign body, so it can rule in if you see the foreign body, but if you suspect a foreign body and you get imaging and you don't see a foreign body, it can't necessarily rule it out because a lot of foreign bodies will not be radio opaque. Let's see, in a constipated child, a rectal exam reveals tonic constriction of the anus with an empty rectum. Hirschsprung's disease, yep, that's another pearl. What was that? Check the throat? Oh, abdominal pain. Yeah, I when I read this, it was funny because in my, you make not all your mistakes, but a lot of mistakes in your first year of practice. And I remember calling the pediatric surgeon to come and assess this child that I thought was a slam dunk appendicitis because they had a sore tummy and they hurt when I pushed on this little 3-year-old's belly. They seemed to be more right-sided. We got the child had a fever, we got a CBC, and they had an elevated white count, and then the pediatric surgeon came in and did a much better job than me and looked in the child's throat and said, yeah, look at that tonsillitis. And so children with belly pain, it may not be focal belly pain, it may be their belly hurts while they're sick, and so give them a good head-to-toe checkup, and that's a just good reminder, and I've always remembered that case. Although very uncommon, UTIs can have coexisting viral infections, sure. Nitrate testing has less sensitivity. That's true positives for a UTI when caused by a gram-positive bacteria. So we all go, woohoo, yay, nitrates, spike the ball, right? It's a UTI. But if they don't have nitrates, it doesn't mean they don't have an infection. If it's a gram-positive infection, it's the gram-negatives that are producing the nitrates necessarily. Migraine headaches in children, rather than sudden onset, intensify over 10 minutes and maximum at 1 hour. Okay, so migraine headaches in children. About a third of migraines in children are unilateral. Okay, ergotamine should not be used in these migraines. A serious cause of headaches will have concomitant neurologic, most serious. Yeah, so if you've got a really bad headache, right, if it's a serious condition, there should be some other hard neurologic sign to tell you something bad is going on. Blunt head trauma in children can be accompanied with diffuse cerebral swelling and increased CSF pressure and altered mental status, sure. And children have concussions should not be allowed to participate in contact sports until cleared by another physician. This pendulum is switching, right? We're seeing more and more studies. It used to be, when I was growing up and playing hockey and stuff like that, you hit your head and you had a clear concussion. It was like I sat out a shift, right? And then it was right back in. Put me in, coach. I want to play. And then the pendulum became, oh, he had a microaggression. It hurt my head. I'm out for a semester. And I'm obviously being facetious about that. But, now we have people that just ding their head slightly, and it's, oh my goodness, right? Now I think the pendulum is swinging back more towards the middle, where it's not like you have to have complete bed rest for like extended period of times. Now the concussion literature seems to be going, listen, you've rung your bell, you've had a concussion, take a couple of days of complete rest, and then slowly increase activities as tolerated, and if your symptoms come back, then you pull back from the level of activity you're on. Because like what in medicine has 2 weeks of of strict bed rest does anything, right? If anybody's here out long enough, they know, we used to put people in bed for 2 weeks if they threw their back out. Watch them get up after 2 weeks of lying in bed. Is their back better? No. And so 2 weeks of strict bed rest. We're seeing more and more with regards to the concussion literature where it's swinging back to a couple of days and then slow progression and return to sports. Children presenting with metabolic crisis, inborn errors of metabolism, resultless of cough, usually dehydrated. It's usually acidosis and hypoglycemia, and that's one of the points I made earlier. Don't give insulin and glucose to treat hyperkalemia in children. They can have a vigorous response and just crash their sugar. Unless clearly vasovagal, to a child, get an ECG. You're looking for things like Brugada and stuff like that. Syncope associated with exercise, so sports-related syncope. You should be thinking about structural problems of the heart as well as electrical. Other risk factors for serious causes of syncope, watch for those family histories and things like that. And loss of consciousness occurs simultaneously with shaking movements, with seizures, but less after loss of consciousness with syncope. So that's the thing when you have somebody syncopized versus a seizure and trying to tease out the difference between the two. That's it. I'll leave it there, finishing on time at 8:45 for Peter. Thank you very much. I'm going to be heading back to Canada.